Thanks to all of you who waited, because we're starting this session a little bit late in what can only be a metaphor for my conference experience. My watch battery ran out, and I'm very, very sorry. That said, I'm also very, very glad to welcome our panelists to this discussion of the impacts of U.S. drug policy on the HIV response, both at home and abroad. I see many familiar faces in the audience, but I think that it is probably fair to say that many of us are familiar with one piece of the puzzle, but the full spectrum of the way that U.S. drug policy impacts HIV and other programming is probably not as clear to any of us, and so we hope to explore that in this panel. Our first speaker is Anya Sarang. She is from the Andrei Rilkov Foundation, which works to promote the health and human rights of drug users and to advocate for sound drug policy in Russia. She, in some sense, has the hardest task on this panel because the influence of the US in Russia is obviously a very complicated algorithm. It's not like Russia loves the US. And at the same time, Russia and the U.S. have some collaborations in unexpected ways on questions of drug policy. So Anya is going to talk to us, and we've asked that panelists keep their remarks only to 10 minutes, so that we have some time for questions. Even with my late arrival, I hope we will have some. So with that said, Anya.
Okay, thank you, Daniel, and thank you everyone for coming to listen to our panel. Well, as you know, Russia is now the worst country in the world in terms of HIV epidemic, and the epidemic is still on the rise, unlike in every other country of the world. And this is related to absence of prevention programs among injecting drug users, who constitute majority of new infections of people with HIV. So we can say that HIV epidemic is driven by the drug policy or bad approach to drug policy in Russia. How is it? Well, the main characteristics of the main international critique of Russian drug policy go against the Russian federal ban on opioid substitution treatment, and the Russian official opposition of the needle and syringe programs that are now positioned as a threat to the national drug strategy. The Russian government does not provide any money for HIV prevention among injecting drug users, and actively opposes harm reduction programs within Russia and on the international arena. Sadly, the Russian official statements about harm reduction and particularly about opioid substitution treatment are often or always backed up with the position of the United States colleagues. Some of you may know that several years ago there was a new initiative between our presidents, and there was some kind of, I don't know, it's called reset button, and they established working collaboration, including the working group on the issue of drugs, which is headed by the Russian drug czar Ivanov and the US drug czar Kirlikovsky. Well, for this presentation, I just prepared several quotes from Mr. Ivanov, who speaks openly and publicly about the federal government position on opioid substitution treatment. And the first quote is from the press conference at the Commission on Narcotic Drugs in Vienna in 2010, where Mr. Ivanov said the following: Russia is against methadone. The world science does not provide evidences for the effectiveness of this method. In this issue, we share the position with our colleagues from the United States. Of course,
which is false. We should just say that it's not correct, and yet he keeps saying it.
Yes, he is not correct. And everybody knows it because methadone is the most studied drug probably in the world, and the volume of scientific evidence behind substitution treatment is massive. Besides, there is no position of the colleagues from the United States against substitution treatment. However, this public statement was not in any way challenged by these colleagues from the United States. And the next year, Mr. Ivanov repeated in the same platform in Vienna CND the same basically statement but with other words. When the Russian delegation has organized a press conference on the subject of fight against heroin production in Afghanistan, he said that there is no evidence that methadone substitution is effective, and to the contrary, there is evidence that it leads to an increase of overdose deaths among drug users. He also said that methadone, this is direct quote, methadone, of course, we are studying this experience, and we studied the experience in the United States, and we see that these results are not clinically proved. I can say that in Russia, a consolidated opinion of our scientific experts, including narcologists and the Ministry of Health, is constantly kept against methadone. Moreover, the world science does not yet dispose of scientifically proven clinical trials that confirm the effectiveness of this method. In this issue, we stay in solidarity with our colleagues in the United States who have the same position. And so on. Again, this was not challenged in any way by Mr. Ivanov, United States colleagues. And next year, again in Vienna, at the press conference, he again repeats that we do not implement the so-called methadone therapy. It is not admitted by the Russian specialists. And this position is shared by a number of countries, particularly United States of America, with whom we closely cooperate, referring to the working group experience. It doesn't solve the problem of treating drug dependency. Besides, the mortality of people who undergo this so-called therapy has increased significantly. At 2012, Mr. Ivanov was referring to this, to his collaboration with the United States government when he answered a question of a colleague about the government closure of my organization's website. And in the same press conference, he accused my organization in distribution of the illegal substance, methadone, in Russia. And basically, he backed up his position with the, with the support or alleged support of his U.S. Colleagues. Again, this year, 2012, he has a meeting with Kerlikovsky in Chicago, where again he talks about the substitution treatment, but this time he sits next to Kerlikovsky, like we sit here with Daniel. So, sitting next to Kerlikovsky, he says, the discussion on so-called substitution treatment, methadone, is synthetic drug that is provided to drug addicts instead of their usual drug. So we cannot really call it a treatment, it's just replacement of one drug with another. By the way, there is a decision of the United Nations in this regard, which states directly in the anti-drug conventions about impossibility of replacement of one drug with another. Of course, there is no such decisions by the United Nations. Methadone treatment is the first-line treatment that is recommended by the WHO and by the UN agencies and so on. So Mr. Ivanov continues. There is no clinical data confirming any positive results. Practically all my partners in Europe and the US, and we discussed it with Gil Kerlikovsky, are disappointed with the results of using methadone. It does not provide the expected outcome, and its use is driven by lobbying of the chemical producers who are interested to sell the substance. So, I mean, this kind of bullshit statements are very normal for a Russian official who can say whatever they want within the country, and nobody ever listens to them and nobody reacts to what they're saying. However, we think that the US government and Mr. Kerlikovsky should react to the statements from his peer, from his colleague, Mr. Ivanov, because these statements, first of all, they are public lies. Second of all, they are used to, to justify the government's illegal action, for example, to close our website, or the government criminal inaction to provide effective drug treatment and HIV prevention for people who use drugs in our country.
Thanks. And obviously,
Thank you, Mr. Ivanov, for providing such beautiful quotes.
thank you to Mr. Ivanov. And Gil Kurlikowski came to a session that we held on Friday, and he actually said some perfectly reasonable things about taking a third way and pursuing health as the outcome of drug policy. And he then went directly from the podium out the door, receiving no questions and offering no opportunity for anyone to ask him about this. I want to turn to Alan Clear now, because actually Mr. Kurlikowski did ask for Alan Clear to meet him at the door of our meeting on Friday, which in and of itself seemed like a landmark shift in the Office of National Drug Control Policy of the US, because there was a time when they wouldn't even say the words harm reduction or invite anyone with the phrase harm reduction in their name to a meeting, and that has shifted. And at the same time, well, I'm curious to hear from you, Alan. So what do you think the effects of US policy are on the HIV response? And do you think that Kurlikowski holds the key?
Thank you, Daniel. I'm curious to hear what I have to say too. It's nice to see such a room full of people. So maybe I'll do that backwards in some ways. We, as Daniel says, that we have had no access up until the Obama administration to the Office of National Drug Control Policy. It was not an institution that we had access to. They wouldn't talk to anyone with harm reduction in their name. They wouldn't use the term harm reduction. And I felt that we have good relationships with places like the public health institutions, like the Centers for Disease Control, a little bit with SAMHSA perhaps. But if we were going to change drug policy nationally and then globally, we needed to have the entree into parts of our federal government that address drug policy. So we could marry drug policy and health policy. Because we had no entree into it domestically, into ONDCP or International Narcotics and Law Enforcement or the DEA or any of those pieces of the federal government, the way we did it quite deliberately was to go to Vienna to do it, to go to the Commission on Narcotic Drugs to meet with the U.S. delegation, which is made up of State Department, ONDCP, International Narcotics and Law Enforcement, and the Office of Global AIDS Coordinator. And it was easier for us to harass delegation in the corridors in Vienna, the Commission on Narcotic Drugs, than it was to get into the door in Washington, D.C. We started doing this right before President Obama got elected, and there was it was the year that there was both a high-level segment of a meeting in Vienna and then the regular Commission on Narcotic Drugs meeting. So it was there for 10 days. It took 10 days to get to the place where they would actually meet with us. And they met with, you weren't there for the second meeting, were you? We had a meeting first with the US mission to the UN, and that apparently turned out to be the tester. If we behaved well in that meeting, then we were allowed to meet with the delegation. And we behaved very well in that first meeting, and we were allowed to have the second meeting. And it was formal and frosty, I would say. And when we were in the airport on the way back, we were told by someone from that delegation that was the first time they were ever allowed to talk to drug legalizers. And which was exactly the way they think about it. Was us, it was OSI, it was Break the Change, it was Human Rights Watch, it was Institute for Policy Studies, it was Washington on Latin America, and all of us are lumped together as drug legalizers. But since that time, we've worked very hard in building up this relationship with ONDCP and building up the areas where we actually think there's grounds to make change. So with the President Obama coming in, needle exchange was an obvious area where the president had already expressed support before his election, and was an area where we could push that in the international arena, that they could at least talk about the science, they could talk about how we have needle exchange programs in the United States, and we could begin to affect both drug policy and health policy in the United States, but also send that message out globally that the US supports syringe exchange. And I think there's two aspects in which US affects global drug policy. One is that the actual exporting of actual policies, and the other is by example. So when we're exporting global drug policies to a country who is a donor recipient country, they don't want to do anything that would jeopardize that funding. The other flip side of it is when you have a country like Russia or a bigger country where they'll look at the United States and the hypocrisy in the United States that we have mass incarceration. Why would we change? Why would they change incarceration rates in other countries if the U.S. is incarcerating more people than anyone else in the world? So there's this by example and also fear of losing funding. So going back to what we were just saying about meeting with Kulikowski, et cetera, and ONDCP, over the years we've scheduled annual and then biannual meetings with ONDCP to move on those issues that we can move on. And sort of what it's about for both sides, or for their side, I guess, is actually beginning to trust the fact that what we say is actually real, that we do know what we're talking about because a lot of us in the harm reduction and drug policy movement have experience on the ground, and that we've actually tested and driven the programs that we're talking about. So whether we're talking about syringe exchange programs, whether we're talking about overdose prevention programs, or whether we're talking about accessing medical services for drug users, or even undoing the criminal justice system, we actually bring in that real lived experience into ONDCP, and they're beginning to trust that, because the advisors to ONDCP were really on the drug-free side. And I think over the last 3 or 4 years, we began to build that relationship. With relationship to the methadone and the exportation, it's at the point where that's almost the first thing that ONDCP will often say to us. Like, I know you want to hear what we're saying to Russia. And what I hear from ONDCP is, yes, they do bring this up every single time with Russia, and the Russians do not listen. I have a certain amount of faith that they do bring it up. It's what is sad in all general respects, I think, for this administration, the Obama administration, is that they cannot say anything openly and publicly that in any way that they think that someone else will use against them. With the Republicans. And that's why I think that Ivanov gets away with lying. I also think that it's a very human trait it may be different if you come from a country that has a history of totalitarianism, that when someone tells me something, I tend to think they're basically telling the truth, and we're not used in the same way, perhaps, to a public official saying the research does not exist that proves methadone works, and it's contributed to overdose deaths in the United States. So we're not quite used to these bald-faced lies, except in political campaigns, which I think is not something we're quite used to responding to, perhaps. I don't know, maybe that's just justification. But we have had conversations with ONDCP about how to change stuff in Russia, and they've put forward all kinds of not very, dynamic solutions to this problem of what's happening in Russia. So I guess, is that 10 minutes?
Well, that's enough for now. I will come back to the question of needles, because I do want to point out that though we're focusing on ONDCP, of course, the U.S. government has a number of different parts, and one of those parts is PEPFAR, and they don't pay for needles now because of the congressional ban, but of course...
You want me to say something?
Well, just maybe one word about that. Not one word, one brief intervention about that.
I mean, along these lines of non-evidence-based stuff, the you probably know that we've had a federal ban on the funding of needle exchange basically since 1988, except for a slight reprieve for a couple of years under the Obama administration. This has affected PEPFAR funding and the way that PEPFAR funding can be used globally. And even up until Obama got elected, there was actually no ban on the use of federal funds for PEPFAR. They just never did it because of fear of a ban coming down. I think that's correct, right? And now actually it's a
ban.
It's a ban now, yeah. So it's actually got worse for PEPFAR. And within what was worked on for a long time was an IDU guidance for PEPFAR that would allow for syringes. It would allow for the procurement of naloxone so that people could begin overdose programs. And it would also allow for medication-assisted treatment, methadone, for HIV-negative drug users in PEPFAR recipient countries. I believe that none of that money has ever been used for any of that because of the fear, because a ban on syringe exchange now on PEPFAR, and because of the fear of what would happen if anyone actually did spend the money in that way.
And just to sort of add, so the fear is not just about the ban, but the fear is that some congressional Republicans said very clearly, if you have money to spend in PEPFAR on needles, you must have too much money. And some people said privately, as far as we're concerned, needle exchange is, quote, the new abortion. And if you pay for needles with PEPFAR US AIDS dollars, we're going to go after the whole program. So it put countries in this very difficult situation, even well-meaning PEPFAR employees, of saying, well, if we pay for needles, do we jeopardize HIV treatment that we're also paying for? Okay, I want to go to Damon now. Damon Barrett is the Deputy Director of the Harm Reduction International. Is that your title now?
That's it.
And he is an extremely skilled and experienced advocate, lawyer, UN expert, and we've heard a lot about what PEPFAR won't pay for. I want to ask you to talk a little bit now about what the U.S. does pay for and what kinds of questions are raised by that and what its implications are for drug policy.
Right. Thanks a lot, Daniel. So as Alan was speaking there, about what PEPFAR would pay for, and Daniel introduced this perfectly. There are a range of things the U.S. pays for that are as abusive that they were always supposed to be. It's not accidental. Now, the thing about this talk, as I was thinking about it, is has anyone seen this movie Swimming with Sharks from about 20 years ago with Kevin Spacey in it? There's a great line where he says, I'm going to be talking in a kind of circular motion, but eventually there'll be a point. So the point here is HIV, right? But I'm talking around it quite a lot, and I think that people in this room will get what I'm talking about. We've been doing lectures at universities about human rights and drug policy for the last couple of years, and when they're new students and they've not seen us before, one of the easiest ways to introduce the topic is to say, name any human right you like. Name any human right you want, and I'll connect it to drug policy really fast. Now, what that really talks to is what we would refer to as, I suppose, the risk environment for human rights. The risk environment, in this case, for injecting drug use and HIV transmission. And so that's kind of the context in which I'm talking. If you name any human right, we're going to connect it to drug policy pretty quickly. I'm going to be talking specifically in a while about the right to health, arbitrary detention, and torture, putting us right into the sharp end, if you'll excuse the pun. It's also in a context of millions upon millions upon millions of dollars and euros spent fighting a ridiculous war on drugs around the world, when we've got maybe a 20th annually of basic need for harm reduction services. It's a grotesque imbalance, and it's something the UNODC refers, or it's a consequence of what they call policy displacement. This is a direct consequence of essentially the US-driven international drug control framework, where almost all of our attention, our research, and our money is focused on so-called supply and demand reduction, but basically law enforcement-based drug control rather than public health. And none of it's evaluated. So, we all know things are largely either the same or getting worse. But there's no accountability for law enforcement spending. Meanwhile, every time you want to start a new methadone program in a country, you have to again pilot it. You have to again test it, which is unethical in itself for a medicine like that that's already proven. And when we talk about the US third way, if you're going to try and aim for a third way, then don't consort with extremists. This seems to be a pretty basic thing, or extreme human rights abuses, which brings me to pull that together. We released this report recently. It's called Partners in Crime, International Funding for Drug Control and Gross Violations of Human Rights. And what we looked at was funding not just from the US, but lots of countries, and where it went to countries where they execute people for drug offenses and where they detain people in drug detention centers and beat and rape and abuse them and deny them health care. And our question was, when does cooperation on drug control turn into complicity with those human rights abuses that are, in most cases, absolutely prohibited in international and national law, by the way? Now, sometimes the things I'll be talking about, we would say that it's an issue of proximity, that you're too close to the human rights abuse. You're giving money generally to Iranian police, and you're in a risk environment there where you really should be thinking twice and three times about doing that. Or sometimes it's direct. So I'm going to give you 3 examples based on US funding. The first one is to legal reform in Cambodia. So the US and other governments gave money through the UN Office on Drugs and Crime to help Cambodia develop its new drug law. Now the thing is, the original brief for UNODC was to help Cambodia strengthen and make more serious the penalties for drug crimes, right? And of course, that changed over time, but what actually came through was a worse law that did in fact do that and actually increase the amount of time people could go to drug detention centers. It also defines as a conspiracy 3 or more people gathering to commit any of the crimes in the law, one of which, of course, is drug use. So people hanging around with their friends, well, that's a criminal conspiracy now. We heard, in fact, from people who were in meetings with UNODC, US-funded and other governments, equating relapse with serial killing. Basically what they mean is here repeat offenders. Let's move on to a more direct one. Here you have funding for treatment within detention centers, or so-called improving and making state-of-the-art the treatment in detention centers. In this case, in a Vietnamese detention center via a US-based private company, Daytop International. Now the thing is, this funding was likely not intended to make people feel worse, but the question was never asked, right? I want to read you a quote. This is a quote from a Human Rights Watch report from somebody that had been in one of those centers. "If we opposed the staff, they beat us with 1 meter 6-sided wooden truncheon. Detainees had bones in their arms and legs broken. This was normal life inside." Now, when did US and Daytop International think that the guy wielding the truncheon was a good drug treatment counselor? When did that ever become a good idea? And then we can go to even more direct forms of funding. Here we have bricks and mortar material support for building drug detention centers. So a while ago, Human Rights Watch released a report called Samsanga's Secrets. This was about a detention center in Laos where people had no provision of health care, or little or no provision of health care, where there were a high rate of suicides and where beatings were common. Now this was US funded. It was all bilateral funding in this case. Funny side thing actually, just after 12 UN agencies called for the closure of all drug detention centers, this ad here came out. This is a fashion show to support Samsanga. You'll see UN Office on Drugs and Crime named on that. And again, just a couple of months ago, the US announces $400,000 for Laos, including support to Samsanga, even though we know what goes on inside. Now, this is denied a lot, but only by those who are, of course, not current or former detainees, because when they ask, they explain exactly what's going on and how the place will get pretty quickly cleaned up when visitors from international outsiders come in. So our report has some recommendations for this, okay, because it doesn't need to happen. There's systematic and systemic things you can do to prevent your money going to abusive programs and practices. So the first thing we called for was very clear international guidelines on human rights and drug policy. That gives you a baseline of where your red flags are and your red lines are. And what we wanted was all current funding to be audited in line with those guidelines and action taken on anywhere where those kinds of red flags were raised. That $400,000 to Laos, for example, that should be frozen. That's pretty clear. And we wanted ongoing, we wanted a system of human rights impact assessments to be taken on board, which would include predictive initial risk assessments. That goes back to that thing I said about the context, the human rights context. We wanted to look at the human rights risk profile of every country where you're spending your drug enforcement dollars. The thing is, internationally, we're always talking about our shared responsibility to counter the world drug problem. The thing is, you have to take shared responsibility for the HIV and human rights consequences of fighting the war on drugs. And that's what we're talking about in this document. Because to see this abuse, as everybody has, to see it documented, and to carry on regardless, that's not unintended, that's complicity. Thanks.
Okay, I see a number of people in the audience from the US. I see some people from multiple other countries, Canada, Russia, some countries I don't know. But we are open both to questions of strategy, like what should we be doing to push the US to be more accountable and to pay for more of the right things and fewer of the harmful things. But also if you have any additional insights on how you think US policy impacts the HIV response either in your country or outside, the floor is open. So would anyone care to pose a question? If not, I can always do it, but I see some hands. But there's a mic here because I think they're recording, so if you wouldn't mind coming to the mic and also identifying where you're from, just so we have some context.
Hi, I'm Connie Carter with the Canadian Drug Policy Coalition. Damien, I just, more of a comment than a question, but I did read your Partners in Crime report. It was great. And I just wanted to say that you also named names and funding sources in Canada that are similarly complicit in the kinds of stuff, human rights abuses that you're talking about. So Canada also plays a similar role in the world stage.
Yeah, this is moving away from HIV, but let's put the human rights in the human rights context. We did document a case of a woman, a pregnant British woman, who was arrested for drug trafficking in Pakistan and was facing the death penalty. And the program that she was caught through was airport screening, entirely paid for by Canada. That's right.
Other thoughts or questions? Yeah, please.
Throwing myself into this. Arild Knudsen from the Association for Humane Drug Policies in Norway. I've experienced in Norway and in Denmark, I don't know if you have, therefore I ask about this, that it's not the rational, science-based rhetorics that goes through to the politicians. It's the showing how people really live. In Denmark, they ask the politicians for years, can you please read the reports? Heroin prescription works. And then, nah, we can't read that, we don't, nah, we're crazy. And then it was an article in a newspaper about a woman that was selling sex to a necrophile. She got some tablets, so she was just passed out, and then, yeah, you know. And that article made the whole country turn. And almost everyone in the parliament said, yes, we have to try heroin prescription. And so also in Norway, we see that. So I think I hope you do that. Use the media, simple persons in their lives, and why they are living in desperation, prostitution, forced to prostitution, forced to criminalization, because they're addicted to illegal drugs.
Okay, let's take another question, and then I'll turn to the panelists.
Hi, I'm Leo Beletsky. I'm a professor at the Northeastern University School of Law and Health Sciences College at Northeastern. I'm sorry I missed most of the presentation, but in terms of some of the strategies, Damien mentioned that one of the things that you've been doing is doing lectures around academic institutions, and I wonder if there's, you can comment on the idea that maybe we need to take a more systematic and institutional approach to integrating these issues of drug policy and the connections to human rights and public health into the curricula of academic institutions, including specifically as someone who works in law schools, in a law school, into law schools, and making sure that people who are going to be policymakers, decision makers, litigators, activists, that they are very well aware of these overarching issues.
Okay, so these are two different questions of strategy that have been raised in a way. On the one hand, and maybe I would put this question to Alan and Anya. So our colleague from Norway was observing that it's actually personal stories and the power of kind of human narratives that shapes these drug policy questions. Why has harm reduction not been more successful in putting forward an image of itself rather than just about needles and evidence, but actually about stories of how people are helped or why the human benefits of harm reduction? And to Damon, because I think that you're the only one among us who actually goes to universities and lectures, etc. What do you think about this question of not just drug policy and human rights, but in terms of public health, actually trying to integrate with organized academic institutions or other educational institutions? So first, Alan and Anya.
So, I mean, I wouldn't say we've been unsuccessful. That might be an overly negative way of starting. I think if you look at sort of historically at where we came from, it was really about programming, and it was really about harm reduction was like setting up programs and then trying to sell them. So there's, and what we were, this accusation, Daniel.
Think of it as devil's advocate.
Yeah, I think of it as it's. I think, I mean, in the last 20 years, we've had, I guess we've had the last 5 years of a friendly Congress. We had a Congress where we won the election and had a fairly friendly administration, and then we had President Obama. And I think in that time, before that time, we really didn't have the entree in some ways to even get the friendly faces in there. The human interest stories, and it was really about we framed this as HIV. We thought that maybe the science would actually compel people, and it really didn't. And it was just this learning curve that actually telling people the science, telling people that it doesn't increase drug use and it decreases HIV, realizing that just wasn't enough. And so maybe that's our slow learning curve, perhaps. But it's also we reached the point perhaps now where we do have more established infrastructures, organizations to be able to do some of the public selling of the human face of this. And I think even right now, I mean, this is an example of still how difficult it is. President Obama didn't want to stand on the same stage as someone with a history of drug use and sex work. At the opening, he was going to be at this opening, and it was controversial that he would stand on the same stage as a drug user or sex worker. If anyone saw that plenary this morning where Debbie McMillan, and that's the person we're talking about, if anyone saw her speak, that is the person that he was afraid to stand on stage with. That he thought that was too politically unpalatable and too controversial, and that would be turned against him and he would lose the election because he stood on the same stage as Debbie McMillan.
Was he afraid, or was IAS afraid?
No. It came from the White House. It came directly from the White House and political advisors that he should not stand on that stage with her. And that's because I think if he'd met Debbie, if anyone had actually asked us what the story was or who she was, maybe it would be a bit different. So even in this administration, we're getting to the point where, I mean, we're not there yet. And there was a second piece to it.
Well, the question, but maybe I'll go to Anya now to answer it, is, so how do we get there? Like, how do we make harm reduction, users of harm reduction or users of drugs, like, how do we get to the human narrative?
We have the human narrative. What? What's going on? Okay.
Can you imagine an AIDS conference where that says needle eyes on their t-shirts? I doubt it.
Okay. So I mean, it's different things to use the stories of people who use drugs or people with HIV, and the human face of the problem in communicating with mass media. But I understand your question was about delivering these stories to the government and try to influence the government's policy with these stories.
Yeah.
Mass media. Mass media, of course, we do it all the time, but the problem in our country, mass media doesn't influence the government policy. It's, no connection, basically. But for mass media, of course, it's our main strategy that we introduce journalists to drug users. We introduce journalists to people with HIV. Just today there was a beautiful story in the main Russian newspaper, Moskovsky Komsomolets, about case managers, our volunteers from Kaliningrad and Tольятти, and the stories of people they work with. It's like, amazing story. So this is very effective and very good in terms of working with media and public, but it doesn't influence the government in any way. It's just different planets.
So, Damon, the question of academic institutions?
Okay, before I get to that one, I want to address the first one as well, because
Okay.
one of the things I thought addressing this question is that maybe over time, and I blame, and I include my organization, Harm Reduction International, as was IRA, and our international conference in this too, that maybe we spent too much time trying to be all sciencey. Now we need all of our evidence, but how much more do we need? And forgot to be emotive, maybe sometimes. And so in that way, we forgot how ethical and moral harm reduction is, how moral a position is. When I think about morality, I think about where's the locus of responsibility in this? Do I judge how this person got where they are? Do I ask myself what I do about it? And it seems to me that if we're not, the harm reduction perspective is what do I do about this? What do we do together about this? Rather than, well, you know what, you shouldn't have got there, so get yourself back out of the situation. So that's something we want to address in our next conference, plug. Which is in Vilnius next year. Now, as to the question about academic institutions, you pretty much described a program that myself and my colleague Rick Lyons started called the International Center on Human Rights and Drug Policy. So, funded, I will have to acknowledge, by Open Society Foundations, both IHRD and the Global Drug Policy Program. We do go to universities around the world. We do connect with different universities, and the idea is very much to educate international relations, law students and so on these issues and the interconnections. For the coming year, we'll have a series of human rights and drug policy debates in 5 or 6 different countries around the world in order to bring these issues out. The first one I should suggest will be Professor Alex Stevens from Kent versus Antonio Maria Costa, the former UN Office of Drugs and Crime head. That'll be in Galway in Ireland, where we started this project.
Thanks. I know that Maxine had a question, but now has to leave. Next question from the floor? Yes?
Hi, Jonathan Cohen, OSF. I know you can't cover every topic on a panel, but I think it would just be useful for this subject if someone could comment on the U.S. reaction to the report of the Global Commission on Drug Policy, which basically called for an end to the war on drugs, and whether the U.S. reaction had any global resonance at all.
Alan, do you want to say something, or I can say something, but actually okay, 2 things. One is the Global Commission report had hardly been out for one moment before the Office of National Drug Control Policy released a statement refuting its premise and basically distancing itself from the report. And the speed with which that occurred, and the speed with which Gil Kurlikowski left the room prior to the speech by one of the global commissioners at an event on Friday, suggests that ONDCP, while saying it's willing to pursue a third way, is really not at all interested in delving too deeply into the conclusions of the Global Commission and what it fears will be legalization. I think my fear is that ONDCP is letting fear of legalization drive it into the arms of partners like Mr. Ivanov from the Federal Drug Control Service in Russia, in the name of distancing yourself from legalization, you align yourself with actually retrograde, illegitimate, irresponsible actors in drug policy. So you had the spectacle the other day, a few weeks ago, or maybe a month ago, of the Office of National Drug Control Policy head Gil Kurlikowski jointly signing a statement with the Russian drug control czar and representatives from the UK and Scandinavia, saying that they're committed to an evidence-based approach, when obviously we know that Russia has no intention of committing itself to an evidence-based approach. I think the second point on your question has to do with how ONDCP is involved in other foreign policy discussions like Afghanistan, which hasn't come up here yet. One of the things that the US and Russia share is that we both invaded Afghanistan and that we both regard Afghanistan as a source of an enormous amount of illicit drugs, and that upsets both countries. But in the name of drug control, the US has allied itself with Russian drug policy, but then said, well, we're not willing or interested in considering any of the health implications or other things that are raised by the Global Commission on Drug Policy. So the fear of the legalizer that Alan described drives all policy to the right and to a dark place.
Daniel, let me ask though. I mean, there has been this incremental progress around acceptance by the US ONDCP and the administration. And I actually think ONDCP is stronger than like the CDC in making statements about something like syringe exchange right now. We've made this progress. It's like how, the question is, it's like we know where they are around drug legalization. The Global Commission report pushes it out there a bit further. The administration does support efforts around reforming in criminal justice. If we look at Seattle, which is de facto decriminalization.
Well,
yeah.
I mean, listen, I agree
But they
completely.
don't think of it like that.
I mean, so ONDCP put out a statement immediately upon the return, or not immediately, but shortly after the return of the needle exchange ban, which very strongly affirmed that needle exchange was an evidence-based important intervention. And while they couldn't support it, they wanted to remind people that it was a part of the continuum of an appropriate response to drug use. And honestly, that statement on their website is stronger than anything that has been publicly issued by the Office of the Global AIDS Coordinator, or PEPFAR, on their website, or even in communications to the field. So I do think that Gil Kurlikowski has shown some genuine, I mean, he also repudiated the phrase, the war on drugs, and the approach to the war on drugs. So I agree, like there is very strong progress. I don't know that I believe that the Seattle program lead is de facto decriminalization, because the police are still the primary conduit to services. So it is depenalization, but it's not quite all the way to decriminalization.
I just want to say really loudly that George Bush was a real disaster for syringe exchange in this country, and is an architect of some disasters and deaths in this country.
And and I believe that Laura Bush may be directly outside of this room. And yes, the war on drugs did not begin with this administration, and it's important that we remember that. Other comments or thoughts before we end?
I wanted to follow. I'm not sure if I can follow on, because I was gonna add another positive or two. So I mentioned Vietnamese drug detention centers. To their credit, when the Vietnamese tried to claim that what was going on inside a Vietnamese drug detention center was in line with U.S. practice, both NIDA and ONDCP came out and said very clearly it wasn't, and that was really, really helpful too, because that just cut the rugs out from it was using the U.S. as a justification. And also, I think Alan and Daniel will agree as well that the U.S. position at the UN has softened considerably during the Obama administration. So now the U.S. will co-sponsor HIV resolutions that recognize needle and syringe programs an OST and so on. Now, while that's contradictory to a federal ban, of course, this is the executive operating at a diplomatic level. So that's helpful too, because it shows that the Russians and some others are quite isolated on these issues internationally, even if they're very authoritative.
So I'm going to give the last word to Anya, and then we will close. Anything you want us to know or to add before we end?
Thank you.
Okay, thank you all very much. There's a session at 2:30 that's called The Nightmare That Is Russia, and Anya will be speaking more there, so if you didn't get enough now, you can hear more details at that session. Thank you.
It's in the...
Oh.
Harm reduction zone. It's in the harm reduction zone.
It's in the harm reduction zone, which is only a few spaces away.